Hi everyone, welcome to this GIE author interview. My name is Lonne Meulen and I'm a PhD candidate at the Department of Gastroenterology of Maastricht University Medical Center in the Netherlands. On behalf of my co-authors, I would like to thank Gastrointestinal Endoscopy for the ability to discuss a recent article entitled Evaluation of Polypectomy Quality Indicators of Large Nonpedunculated Colorectal Polyps in a Non-Expert Bowel Cancer Screening Cohort. For large colorectal polyps, endoscopic resection is the first choice of treatment. If we do not suspect any submucosal invasion, endoscopic mucosal resection, or EMR, is the preferred treatment modality. Current evidence suggests that quality of EMR of large colorectal polyps is good. However, there is a clear lack of standardized training programs for performance of these EMR procedures. Therefore, results on population level, so for endoscopists that are broadly trained but not specifically dedicated to large polypectomy, are still unknown. With our study, we aim to evaluate quality of large polypectomy on population level. When we compare our population of endoscopists with expert endoscopists based on several quality indicators, we see a clear gap of quality from a lesion size of 30 millimeters or larger. So from 20 to 29 millimeters, the quality of polypectomy between expert endoscopists and non-expert endoscopists are the same, but from a lesion size of 30 millimeters or larger, the experts perform better than the non-experts. But we have also seen that endoscopists dedicated to large polypectomy in their center perform better compared to endoscopists that are not dedicated to large polypectomy. So based on this, we can draw the following conclusions. First, results on population level are not the same as those on expert level. Secondly, a clear gap in quality appears from a lesion size of 30 millimeters or larger. And third, if endoscopists are dedicated to large EMRs, the results are better compared to the results of non-dedicated endoscopists. So this suggests that proper training and dedication in removal of these large polyps will increase success rate and eventually also decrease the costs of large polypectomy. So what should now be the consequence for daily practice? Well, we think training is essential for improving outcomes on population level. As we have seen in learning curve studies, they showed that you need at least 100 to up to 300 procedures to complete the learning curve for large EMRs. So it seems reasonable that increasing the number of procedures for specific endoscopists lead to better outcomes. So this implies not only additional training of endoscopists to create a dedicated EMR endoscopist, but also it implies that we need to centralize the care for large polyps. So this centralization can either be to specific centers, but it can also be specific persons within your own center. Well, in the Netherlands, we decided to train dedicated doctors in several centers to evaluate whether this additional training improves the outcomes of large polypectomy. Currently, we are excitingly awaiting the results, and we expect them at the beginning of 2022. Thank you for your attention.